Yep, they sure
Hey
do.
guys, thanks for coming. Nice crowd. Dr. Zhao's out this week. I think he's at Yellowstone National Park. So, for a family reunion from all over the world. So we don't have anything prepared specifically. This is going to be more a Q&A. This is your night to Q&A. So who wants to start off?
I told them all bring their questions, the ones that want to listen.
Yes, sir.
Okay, you know how you're supposed to stay off of alcohol and coffee? What about decongestants? Which ones are okay? And
They're all bad.
I thought Flonase was okay.
Oh, anything based on steroids are okay. So anything that's steroid based is okay. Anything that has pseudoephedrine is bad. Pseudo, pseudoephedrine. Bad, bad, bad. You commonly see it in the decongestants because it's got, for example, Mucinex is expectorant, but Mucinex-D has got pseudoephedrine in it, which is bad. So anything you typically see with a slash or a hyphen with the D on it is a known trigger for Afib. So the trouble is that most of the stuff that really works well is the stuff that causes Afib. That's the dilemma. Now, Aspirin is not really great for you, but it's probably the lesser of the evils. And you just take a squirt of that, but you're not supposed to use it more than 1 to 2 days. Because Aspirin is actually absorbed too. But it's better than the oral things like Sudafed used to be the most notorious. It had the highest concentration because it worked, but it also caused more Afib than anything else. So a lot of patients get frustrated with that. So let's broaden that question to just the common cold. What do you do if you have Afib and you have the common cold and you feel miserable? Well, a lot of folks will take NyQuil because they want to get knocked out. You know why NyQuil knocks you out, huh? It's a combination of a little bit of alcohol and Benadryl. Benadryl by itself makes you sleepy. You combine it with a little bit of alcohol, it's a knockout punch. And it does make most people feel better. But it also has pseudoephedrine in it. So NyQuil in general is bad for you.
But not Benadryl, huh?
Not plain, pure Benadryl can't hurt you. It'll make you groggy, but it can't hurt you. So what you want to do during a cold is avoid dehydration, because dehydration is a known trigger for Afib. I saw 2 patients this last week with dehydration-induced Afib, both working outdoors, had no other prior history of Afib, and just simple dehydration could trigger Afib. So coughs and colds make you particularly vulnerable to have recurrence of Afib. Pneumonia is probably the single biggest predictor. If you have pneumonia and you've had Afib before, there's a 75% chance you'll go back into Afib with a pneumonia episode. So simple things like making sure your Pneumovax vaccine is up to date. Everybody's had Pneumovax vaccine. I know a lot of patients are leery of vaccines, but Pneumovax vaccine is a lifesaver. So those kind of things, protecting yourself. Flu vaccines don't work very well. I mean, every year the strains are different, and the efficacy of the vaccines sometimes are questionable. But even if it doesn't work completely, the severity of the flu seems to be less. So make sure you're up with your Pneumovax and your flu vaccines. If you do get a cold, you got to stay hydrated, particularly with something with a little. You got to be careful if you have a congestive heart failure. You want to avoid high salt compounds. Just simple pure water. And avoiding the things like pseudoephedrine and some of these compounds. If you have a question, call the office. We're very happy to take those questions. If you say, can I take this? Sometimes we don't know the brand name of the compound. If you text it to us with the list of ingredients, we can answer that question pretty quick. But there's like pseudoephedrine is the major evil. And NyQuil has it. You got to be careful what you take. Some of these things disguise the pseudoephedrine. Plain Mucinex to clear secretions is okay, but Mucinex-D is treacherous. So hydration is the main thing, and getting good sleep. Not letting yourself get exhausted, because exhaustion is another trigger for Afib. So that in general, we get that question a lot about, what do I do because nothing works? My nose is clogged up, I can't breathe, I'm miserable. Can I take 1 or 2 Sudafed equivalents? Well, you can do anything, but you know, the chance of going back into AFib goes up. So simple Afrin, if you have to, and use it very sparingly, can give you some symptom relief for a few hours. You gotta be careful about these irrigation pots, neti pots. Sometimes they got bacteria, they can cause sinus infections. If you find you're developing fever with your cold, that's a bad sign. It usually means you're developing either bronchitis or more usually sinus infection. Particularly if your sinuses are tender, seek help with that right away and get treated quickly because that will trigger you into AFib. Any infection can trigger you into AFib. Hydration is a key component, but most times we reassure patients that stay hydrated and they say, I still feel miserable. And you know, a bad cough and cold I can sympathize with. But you gotta be wary about the risk for pneumonia. So again, stay up with your pneumovax and your influenza vaccines. That's gonna come up in a few months. We're getting the cough and cold season. Protect yourself, you know, particularly if you're elderly and you've had some infections. Going into big crowds and shaking a lot of hands is probably not the wisest idea unless you bring your hand sanitizer with you. You know, you got to realize how many of these things are spread by hand-to-hand contact. You know, going into big crowds and shaking a lot of hands. You know, I hate to say it, but your children, your grandchildren many times, they'll be at the daycare and they'll bring stuff back. I'm not saying don't hug and squeeze the living daylights out of your grandkids. I just got 2 new ones, but you got to be careful that they don't bring stuff back to you. Yes sir, I'll come to you next.
Oh, you know, once you get AFib, you run into a lot of people who have it. And I want to give you 2 situations. One, I had a friend who just developed it, and he was seeing a cardiologist. I don't know if there are any electrophysiologists in Lafayette. But the cardiologist just put him on a blood thinner, Eliquis, and didn't do anything about a heart rhythm drug. And another person, another situation, someone developed AFib, and shortly thereafter they had a cardioversion. I just want you to comment.
It depends on, okay, so the question is, why do some doctors choose different initial treatments for AFib? So there's an excellent EP doctor in Lafayette, I know him well, Dr. Welch. He's very good. He's a nice person as well as being a superb heart rhythm specialist. So I don't know which one your friend saw, but
You just saw a cardiologist.
But the first step is always to determine what the stroke risk is. And so almost everybody would get a blood thinner. I would bet both of your friends got started on blood thinners. Then the question is, do you try to restore normal rhythm or do you accept the AFib? Particularly in an older, frail patient who doesn't do a lot, many times not subjecting them to some of the evils of the drugs and accepting AFib as rhythm of choice is the better option. On the other hand, some doctors are just not very aggressive with treating AFib, and they let too many patients stay in it. So I would have disagreements with some. There's no uniform agreement, but if you take 10 different specialists, you're going to find a wide variation. Now, what's going to be common to all of them is that they're all going to follow what's called the American College of Cardiology / American Heart Association guidelines, which you can look up for free on Google. You just punch in ACC guidelines for AFib, and you'll get a PDF that is about a 40-page document. But common to all the treatments is going to be the fact that the majority of patients are going to be assessed a CHADS VAS score, which is a stroke assessment risk, and if they're above 2, they're all going to be put on blood thinners. So I bet both of your friends got blood thinners.
Yeah,
Then one got cardioverted and one they just let stay in AFib. Is that correct?
He doesn't, one of them, he doesn't know that he's an AFib, and he just got put on the
blood
Eliquis.
The Eliquis.
The other one, you know, they put it, but shortly thereafter he had a cardioversion.
So patients who are symptom, 1/3 of patients with AFib, it brings them to their knees, and they're just so miserable they can't function. Those are the patients you consider early cardioversion. It varies with the practitioner. Unfortunately, a lot of the primary care doctors too often just let patients stay in AFib, and then we'll see them 1 or 2 years later, and they'll say, what are my options? I want to get off the blood thinner. And once you've been in AFib for more than a year continuously, the options shrink. So I don't know anything more about that, whether the treatment was appropriate or not. Sometimes patients will say, I don't want to be put on medicines, I'll just accept the AFib. See, 1/3 of patients don't feel anything. I mean, how do you make someone who's feeling good better? When you think about it, I mean, we'll see the patients. I saw a gentleman today who's actually a physician, and he's been in AFib for 5 years, and he's totally asymptomatic. He has no symptoms at all. I saw him on the West Bank, and I said, well, how is the AFib affecting you? He said, it doesn't bother me at all. He says, I want to come off the blood thinners. But that's a bigger question, because there's no data to suggest that if you're able to restore sinus rhythm, what the timing of coming off blood thinners is. That's a big unanswered question that we just don't know the answer to. If you read those guidelines, it'll tell you all the reasons to start a blood thinner. It won't tell you much about when you can safely stop a blood thinner. That's a big gap in the knowledge base. We just don't know. But that's a good point, though, because what you're raising is, why do some doctors do one thing and other doctors do other things? They all are going to assess the stroke risk, though. Now, I do find that primary care doctors are a little bit lax. If they get let's say, a real elderly patient, they'll say the patient's got a fall risk, and they'll say, I don't give the drug. That's not good medicine, okay? Fall risk is fall risk, but stroke risk is 10 times higher. So I tend to be much more aggressive with the blood thinners.
What about with the rhythm drug?
So let's take you through the thinking of the doctor. So the first priority is to protect you from stroke. Now, what if you've had major bleeds? This can get very complicated. What if you've had major bleeds and you develop AFib and you've got diabetes and hypertension, which are 2 of the risk factors for stroke, and you've had major bleeds? Then you're really between a rock and a hard place, right? Because if you give the blood thinner, you run the risk of a major, even life-threatening bleed. If you don't give the blood thinner, you run an 8 to 12% risk for stroke. That's what 2 risk factors mean. If you've got 2 risk factors, you run an 8 to 12% stroke risk. If it's you, it's 100%. So that's where the difficulty comes in. So the next step is an assessment of, am I going to try to get the patient back in normal rhythm? So what's the way we do that typically? Once you're in AFib, what's the only way to get, other than surgery, as Dr. Brothers, is to put the paddles to the chest while you're asleep and just deliver an electrical jolt to reset the heartbeat. There's a misconception among some patients that cures AFib. It doesn't. It just merely resets it. And whatever stimuli were there to set it off could come back and start it again. So typically, the other mistake I see amongst, I don't want to say mistake, it's a difference of opinion about how it should be handled, is I almost always would have you on something that if you got cardioverted, you're not going to go right back into AFib. Some of the primary care doctors, they cardiovert off of antiarrhythmics, and the patient goes back in AFib 30 minutes later, and they wonder why. You know, so my preference is typically to be more aggressive in trying to restore normal rhythm. And then, what drug do you use as a toolbox of drugs? They're all bad. Unfortunately, they're all bad because they don't always work, but some of them can actually hurt you. For example, amiodarone long-term can affect your lungs and liver, sometimes in a dangerous way. A drug like sotalol can cause rhythms to occur in the bottom chamber of the heart. Those can be dangerous. Most of the time, the drugs just don't work as well as we should. So if I saw one of your friends and they were in AFib and they were mildly symptomatic, they'd be started on a blood thinner, and you'd say, why don't you just go ahead and cardiovert them? Well, the guideline, if you read it, says you have to be on a blood thinner for 4 weeks before you try to shock the heart back. You don't typically go right away, because what if there's a clot and you shock the heart? The act of shocking the heart could dislodge the clot and flies out to the brain. So you got to do it step by step. Blood thinner first, and then start heart rhythm drug maybe a week before cardioversion, and then cardiovert. Does that kind of make a little bit more sense to you?
Yeah, but I've been on my blood thinner and my rhythm drug for a year and 4 months. Do I stay on that permanently?
So what happens if you restore normal rhythm? So let's say your friend, I won't say you, so he gets put on blood thinners. Now, if you get put on a blood thinner, what's your stroke risk on a blood thinner? Is it 0? No, nothing ever goes to 0. So he gets put on a blood thinner, he gets put on an antiarrhythmic drug, he gets cardioverted back. Then the question is, which is not easily answerable, is how long do you stay on the poisons? That's a tough question. It depends a lot on what you know about the patient, what their risk for recurrence is. Most patients, it's a minimum of 6 months. Because if you look at studies where you've been converted, if you come off the antiarrhythmic drug in the first 1 to 3 months, the recurrence rate is very high. So most doctors would stretch that antiarrhythmic drug at minimum of 6 months. Most a year.
Most a year?
I think most doctors would keep you on at least a year.
What happens after a year?
Then you got to sit down and have a discussion with the patient about sooner or later we have to find out if you can fly solo without the drugs. And I typically advise we come off them and reassess. Now what's the downside of that approach?
Throw it into AFib.
You may go back into Afib again. What's the downside of staying on the drug?
Side effects.
The side effects of the medicines, and you're committing somebody to lifelong therapy who may not need it. So common sense tells you that sooner or later you want to assess off the drug. Does that kind of make sense? Am I confusing you more than I'm helping with the... So you want to know why you're still on the drug. Anybody who's been converted back to normal rhythm can stop the drug.
I haven't been converted though.
Are you still in Afib?
Every so often, yeah.
So you're going in and out.
Yeah.
So if you see an in and out pattern on a link device, for example, you don't want to stop the antiarrhythmic. Because if you see that pattern, you know if you stop the drug, it's going to become more persistent.
So I could be on it for the rest of my life. Okay.
Yeah, unfortunately. I'm sorry, the lady in the back first. And
I just wanted to ask what to take for regular pain, like a headache or an arthritis, or I just had a torn meniscus and I didn't take anything the whole time.
so again, I'm going to take your nice question, I'm going to generalize it a little bit. This comes up all the time. There was a gentleman in the back. If you have chronic musculoskeletal problems and you put on a blood thinner, what's the common remedy for musculoskeletal problems? Aspirin or Tylenol, or more commonly a vast array of what are known as non-steroidal anti-inflammatory drugs, right? You can buy over-the-counter Motrin and Aleve and things like that. Those are non-steroidal. They don't have steroids in them, and they're anti-inflammatory drugs. The trouble is, when you add a blood thinner with a non-steroidal anti-inflammatory drug, the bleeding risk goes up. So we get asked this question a lot. Can I take Mobic or Aleve or Motrin for my terrible knee pain? I can barely function without it. And the answer is we can do anything at a level of risk. So if we use, let's say for example, let's take one. Take Eliquis or Coumadin or Xarelto. Take any one of them. And you add a non-steroidal, the bleeding risk goes up by about 20–30% over the next 1 to 2 years. That's if you take it every day. If you take it hit or miss, the bleeding risk is much less. Unfortunately, nature set it up to where that's a problem.
What about Tylenol?
Tylenol doesn't seem to affect the bleeding risk that much. Tylenol is a lot safer.
So I can take Tylenol.
Now, what if you take aspirin? Aspirin definitely additively increases the bleeding risk. What if you've got a stent? I call it the triple evil. Is you've got Afib. You've got Afib, so you need a Coumadin type or non-Coumadin type blood thinner, and you've got a stent, and you need Plavix and/or aspirin, or Effient and aspirin, and you got bad muscle aches, and you want to take a non-steroidal. That's a triple whammy. That bleeding risk at 1 year is 40%. And most of them are minor bleeds, but they're significant bleeds. So you can't stop. A lot of patients say, well, I'm already taking, let's say, Plavix from my stent. Why can't I just take that? It's because the studies have shown the way Plavix works is not protective against the stroke risk in AFib. Wouldn't that be nice if you could just take one for all? But it doesn't. So a lot of our patients, how many patients in here are taking a Coumadin drug or Xarelto or Eliquis? Now how many are also taking aspirin with it? There's some. And how many are taking something like Effient or Plavix on top of it? See, in a younger patient, it's not that big a deal, but as you get older, that risk goes way up. So that's unfortunately we call it a lot of names, but our GI doctors, we get involved, we get to know them very well. But a big misconception among patients is, well, I'm taking aspirin, isn't that good enough? The studies with aspirin have been very disappointing to prevent stroke and AFib. In fact, it's rarely used alone. It's such a poor second. Well, why can't I use Plavix and/or Effient or Brilinta? Anybody on Brilinta? It's similar to Plavix or Effient. The trouble is that those drugs, unfortunately in the studies, have not been shown to be protective. So you got to use combinations, and the combinations are treacherous. Now, what happens if you can't take any of these drugs because you've bled? That's when we're really between a rock and a hard place. Well, there's something new that you may not know about, and it's going to grow in popularity, and that is there are mechanical devices that can be put in or placed that occlude the part of the heart where the clots come from. Anybody know the name of that structure?
Appendage.
The left atrial appendage is where most of the clots come from. So you can go in through the leg vein and take this umbrella type looking device. We had a talk on it. And you can place that in the appendage, and it's been shown that if you have that done, you don't need to be on the blood thinner. It's as good as the blood thinner. We've got a gentleman who's had a hemorrhagic, no more cases of it. He's had a hemorrhagic stroke in his brain. And the neurologists say you cannot, under any circumstance, put him on any blood thinner. And he's in persistent AFib. That's the only option for him. So there's a technique to do it through the leg vein. It's called the Watchman device. And unfortunately, East Jefferson won't commit the finances to get that for us. They've had a few problems, as you've read about in the papers, with finances. Because it doesn't tend to make the hospital money. It's typically a money loser. So we can't use it, so we work with our friends at Tulane. We send some patients, the group there, that have gotten it. Dr. Brothers does a beautiful alternative to it, which was probably something I would want for me if I needed it, is where he makes a little tiny incision in the chest wall, and puts basically a rubber band around the appendage. It's called the AtriClip. So if you're interested in reading about those two devices, the first one is called Watchman, W-A-T-C-H-M-A-N, if you punch that in Google. It's the umbrella. Now what worries me about the umbrella a little bit is that there have been a few dislodgements of the device, which is not good. They've had to be repaired surgically. It's unusual, but it has happened. But the studies are very clear that if you have an occlusion device, you're just as good as if you took Coumadin every day or Xarelto every day or those drugs. So you're going to see a lot of patients, I think, opting to have that kind of treatment rather than take blood thinners. I mean, it's an added step, it's another procedure, but for most patients, it's a better alternative than risking GI bleeding. We had one patient bleed to death on anticoagulants. We couldn't stop. I mean, he was found basically in his apartment. So these drugs are, they're not benign drugs. So that's what's new. That's the latest, greatest. We can't offer that. We can offer the AtriClip here, Dr. Brothers, and it's beautiful when you see it because the appendage is perfectly sealed off. And I've never seen a stroke in anybody who's had that treatment. So a lot of patients in here may want to consider that down the road.
And the AtriClip just takes care of the AFib?
No, it doesn't fix the AFib, but it seals off the pouch. I wish I had the heart model here with me.
It makes sense now. I hear what you're saying.
So if you were to open the chest,
You guys are on the side, right?
yeah, you've got a patient who's had it.
Mhm.
He makes a small incision, it's a tiny incision, and he's a master with the scope. If you were to open an incision right here, you're almost looking down right at the appendage.
Okay.
And he carefully dissects the tissue away, he isolates the appendage, and he basically puts the equivalent of a rubber band.
Gotcha.
I mean, it almost looks like a big rubber band around it, and with time, it sloughs off. That's totally sealed off, and that is, you know, you say, well, I gotta have my chest have an incision here. Well, I don't know, I think I might rather have that than have the risk of bleeding from Coumadin, you know? So those are we call them non-pharmacologic options for controlling stroke risk. And they've been very successful. Now, there's another one coming out, it's made by Gore-Tex, you know what Gore-Tex material is? It's an alternative to the Watchman, it's in clinical trials right now. And there's two others in development, both of them in Europe. But what's available locally here is Watchman. And again, EJ just right now can't commit to that. We've tried to get it. And the AtriClip. And there's been no comparative studies of which one is better, Watchman versus AtriClip. We've had maybe, Sharon, how many?
AtriClips that we've staged over.
No, total that we referred to, brothers.
Yeah, he's probably gonna,
Half dozen?
yeah, at least, no, more than that.
Yeah.
Because
Mr.
I think
Jensen wants two.
we've staged about 6.
Yeah, and all the patients have done well. We've never had a problem with it. What's nice is that then you can even if you stay in persistent AFib, your stroke risk is very low. And if you're totally asymptomatic from the AFib, and your main concern is the bleeding, that's a good option. A lot of docs don't even know that's available, but you know, since we deal with AFib a lot, we deal with it.
How is it that you don't go to something like this clip for one of the blood thinners?
How come it's not what we call frontline treatment? I think it's going to become frontline treatment. It was just, the Watchman trial just got completed and finalized by the FDA about 1.5 years ago. So it's becoming increasingly used. It's costly. You know, hospitals tend to, EJ's assessments of that, we would lose money putting it in. And my point is, we're here for the patients, we're not here to, you know, we're here for your interest. I mean, but the hospital has had some financial problems, so it can't offer it right now. In the future, it probably will. But there is the AtriClip, and there's some new ones. I think the Gore-Tex device, which is in development, at Herman Hospital in Houston, they have it as a clinical trial. I think that's good. I think many patients are, let's take a vote. Who would, given the choice of having something put in through the leg vein and not have to take Coumadin versus Coumadin or its equivalent, who would pick the mechanical device and who would pick the drug? How many would pick the drug? Okay. So it's I don't know, it's kind of balanced. But many people would not want to take the drug.
Caused my brain to bleed. One of the blood thinners caused my brain to bleed, and I had a stroke.
And when the brain bleed occurs, the neurologists are never going to let us, for the most part, ever put you back on it.
Well, that's
So,
what he told me.
you know how frustrating it is to sit across from somebody and say, we're between a rock and a hard place?
It was terrible.
Yeah. Yeah. I've got another patient just like you that I'm sorry, I lost track of who's next. So that's an important topic. What do you do? Because many patients come to us self-referred, or they say, I don't care what you do anything. Open my chest, get me off the blood thinner. And that was actually something that we could do to get you off the blood thinner. That's been shown in clinical studies, not just our belief, that has been shown in clinical studies to reduce substantially the risk of stroke. Does it take the risk of stroke to zero? No. Nothing ever takes the risk to zero. Because not all the clots come from the appendage. I mean, they have clots that come from the carotid artery, they have clots that come from other parts of the heart, but most of them come from the appendage. So this is available clinically now, the Watchman, and again, if you're interested in that, we send to Dr. Abarafi and Johnson at Tulane. Ochsner also has it, and the AtriClip we do here. And if you're interested in reading about this, just punch in any of those terms, or Sherry can get you some information about occlusion devices and new treatments for stroke risk.
Dr. Zhao spoke on that. It's on,
Dr.
should be
Zhao
on-
gave a
it was
talk.
on-
It's
it was on,
archived,
it's on the
actually.
website.
Yeah,
I have
I'm
a
sorry,
CPAP question.
I'm gonna come back to you. Yes,
I'm
sir.
sorry.
You got the floor.
Is there some particular amount of use of the CPAP per night that's important?
Yeah, there's this big study just got published. It didn't show a big advantage in survival, but the patients only wore it for 3 hours. You probably have to wear it through most of the night to get full benefit.
Do, but every now and then it really gets aggravating.
Yeah, I saw a lady today, it was amazing. She was having 58 desaturations an hour. I mean, basically she was suffocating 58 times every hour. And she said, is that why I'm falling asleep all day? Because she never goes into REM sleep. She never goes into REM sleep. And she can't start an exercise program because she's so exhausted that she doesn't have the physical energy to go start an exercise program. So she keeps getting heavier because she can't exercise. She wants to exercise, but she's so physically exhausted that she can't do it. So it's a vicious cycle. She's got sleep apnea, and then she's exhausted, she can't exercise, she gains weight. The sleep apnea gets worse. I mean, y'all have heard of Reggie White, the Green Bay Packer lineman who died in his sleep. He had severe sleep apnea. So sleep apnea, the question you had is there a number of hours? There's nothing in the literature, but most authorities think you've got to stay on it pretty much the whole night. Unfortunately, because a lot of patients, we actually had a nice sleep apnea talk too we've archived.
Dr. Eisworth's on the website speaking of it.
If the sleep apnea is not controlled, the AFib will never be controlled. I just gave a talk on is AFib a preventable disease, and I focused a lot on sleep apnea. Sleep apnea does some really horrendous things to you. So I hope that answers the I'm sorry, so you had a question?
Where do pacemakers fit in all this?
So what's a common question is, why can't you just put a pacemaker in
Right.
and my AFib will go away? In some patients, they go into AFib because their heart rate slows, and putting a pacer in does help with it, but what does a pacemaker do? A pacemaker is basically a clock. And if the sensor in the pacemaker doesn't see a heartbeat, if it goes too slow, it sends out a pulse to pick it up. That doesn't do much for your AFib. If you're an AFib, it doesn't do anything. The pacemaker just shuts down. It doesn't do anything. Many times we'll put a pacemaker in and then come back and cauterize the wire between the upper and lower chamber. So the analogy I like to use is you're putting the car in neutral. Okay, the upper chamber can fibrillate all at once, and it's trying to send electrical signals down to drive the bottom fast. But if you cauterize that little nerve, you basically separate them. Then the pacemaker controls the heartbeat. And for some patients, that's a godsend because their symptoms are better and they feel better. We consider it kind of a last resort treatment. So we rarely, if ever, use a pacemaker to treat AFib. But there are patients, for example, whose heart rates are in the 40s and they go in and out of AFib, and you want to start them on an antiarrhythmic drug. Well, all the antiarrhythmic drugs slow the heart rate down. So without a pacemaker to control the slow, you can't give the medicines to control the fast. And there's a name for that if you want to look it up too. It's called Tachy-Brady syndrome. I know some of you have that syndrome. It's very common. So pacemakers in general, they're not a primary treatment. Yes, sir. You know.
I recently had to get my gallbladder taken out. I'm on Plavix and Eliquis. And because I was on Plavix, I had to wait 7 days before they could do the operation. Is there anything that you can take that you don't have to wait 7 days for?
So you were on Plavix and the surgeon wouldn't operate, he was afraid of bleeding.
Correct.
So here's another big question is, can I use something to bridge? It's called bridge therapy. It's typically Lovenox.
Yeah, okay.
So Lovenox is used. For example, my 85-year-old father-in-law last year
So-
kept having sinking spells, and they misdiagnosed him and said he was having TIAs. And one Sunday over coffee, I said, tell me exactly what's happening. Just go from the beginning, tell me what's happened. And a TIA is like a mini stroke, and it always affects one side of the body. He wasn't having TIAs, he was having sinking spells. His whole body was shutting down. So when we knew he had aortic stenosis, a bad valve. But when we cathed him, we found that he was living on a trickle of blood through what's called the left main coronary artery. And he had been taking Plavix. And so really, he only had a few weeks to live, because if that little trickle shut off, those sinking spells, he was trying to die. And so when he got his angiogram, I said, oh my God, we gotta move fast. And we got him in the hospital, and he was on Plavix, and the surgeon said, we gotta wait a week. I said, no, he's not gonna last a week. So we had to operate after only a few days off Plavix, and he bled like crazy when he opened his chest. And one of Dr. Brothers' best moves was, he called me and said, I know he's been on the table a long time, but if we close his chest, he'll bleed. So we waited 3 more hours, and it was election night. And so my father-in-law came through this surgery fine. He's working out 5 days a week now. But the surgeons are afraid of Plavix. Okay, they're terrified of Plavix, because when you cut through tissue, it doesn't just bleed with a bleeder and you can cauterize it. Everything oozes. So you did okay with your gallbladder?
Yeah, it did, after Dr. John told him what to do.
Yeah. Typically it's a bridge.
Put me on Lovenox.
Yes, it's a bridge
I was
therapy.
taking shots in the stomach for
Yep.
3 days.
I'd rather be on Lovenox than be on Plavix going into surgery.
Yeah, no, everything worked out fine.
Okay?
Well, May the 16th, the three of you, Dr. Brothers, you and Dr. Joe, I guess they punched 3 different holes in me and went. And I tell you what, I can't get over how good I've felt ever since.
I don't do any of the hole punching.
But anyway, well, I went to see Dr. Brothers a little while later, and you had prescribed some medicine for me, and you put another doctor's name on it, and Dr. Brothers had a conniption fit. I forgot Dr.
I remember that.
Another doctor.
The pharmacy misspelled your name, and I thought it was,
No,
was it
Dr. McCann or something.
McDonald, huh?
They put another doctor's name on it?
Oh, he was
That's a
upset.
bad mistake.
Yeah.
That's a legal
But
mistake.
actually, like Dr. Brothers goes up first and he goes.
I wish I had, we didn't have the heart model.
I don't have the heart model.
I wish I had.
Okay.
Next time we meet, I'll bring the heart model and I'll show you exactly what he did. It's actually very simple. And what's nice about you say, why do the AtriClip in the Watchman? The Watchman umbrella, when it's put in there, let's say there's a size discrepancy. There have been patients where the Watchman has dislodged and it's been a disaster. Whereas the AtriClip is done on the outside and it makes a nice flush seal. There's nothing to dislodge basically. I mean, the complication rate from the AtriClip is much less than the complication rate from the Watchman. Now the advantage of the Watchman is that you can do it through the leg and you don't have to have that incision in the chest.
I got a little one.
Yeah, and the upfront pain is a little worse with the way you had it than down here. But you're gonna see these things grow. In fact, it's already coming up, there's a national symposium coming up next year where they're probably gonna recommend or offer patients that as frontline treatment as an alternative because the data's looking so good, those options, rather than take Coumadin and
Well, everybody at church comes and says to my wife, she's the secretary at St. Christopher, and they'll come say, his color's back, his color's back.
Well, clipping the appendage is a good thing for stroke risk. I think I really think you did the right thing.
Before the operation, my wife had called a godchild in Dallas, and he's a head pharmacist at one of the hospitals over there, and he said, We don't do anything like that, we just open everybody up. At the
Oh,
hospital he was at, I don't know.
In
20.
Dallas?
Mhm.
Most of the programs in Dallas are pretty sophisticated. They offering, some of them are doing clinical trials with the Gore-Tex device.
I didn't speak to him, I mean, that's, he told her.
The nice thing about Brothers is all those thousands of hours he developed, Brothers can take a lung out through an incision out like that. And, you know, for patients who have lung cancer, rather than have the whole chest open to make an incision, and he's got the skill to take a lung out, that incision, that skill is transferred over to the AtriClip. So you got one of the best guys in the South doing it.
Well, I told my wife, she
I'm a
kept,
big fan of Dr. Brothers, as you can tell.
she was quite worried for quite some while, and I told her, I said, I tell you what's gonna happen, I said, they're gonna come and film everything and have all kinds of doctors come learn how to do all this. And I said, and we all gonna make money.
Yeah, he teaches doctors around the country how to do it.
I can
It's
imagine.
not considered a money maker for the hospital.
But it saves a lot of patients.
Yeah, it's a service, I think.
I mean, I can't get over how much better I feel.
Yes, sir.
What is the pre and post operative to be expected with the Watchman and the atrial clip? You know,
So the AtriClip, we've got somebody who can tell you exactly. So the AtriClip's the incision.
and how long
Right here.
does it take to recover, to get out of the hospital from
It
that?
took me 3 days.
Yeah.
So you're in the hospital for
But
about,
Mainly
now
because you gotta
first
watch for
operation.
bleeding.
And the other one, I was in 4 days altogether.
Yeah. It's basically a 2 to 3 day procedure. Now for the Watchman is typically an overnight stay. So length of stay in the hospital is a little bit shorter with the Watchman. I think the successor to the Watchman is going to be better. The Gore-Tex device is going to be better, and Amplatzer, another company, makes one. There's a bunch of companies developing them, but only the Watchman's been through the multiple clinical trials to show its safety and success. Yes, sir.
Next question about ablation. When Dr. Brothers goes in and goes behind the heart and cauterizes the vessel that you spoke about, does that damage the heart?
Yeah, by definition, anytime you do ablation, you damage a part of the heart. So the thing is, the part of the heart he's damaging is called the back wall, the posterior wall. It's tethered to the rest of the chest by the pulmonary veins, and it's not contributing a whole lot of function to the atrium. Most of the atrial function comes from the front wall, so damaging that area, what he basically does is he scars it up. So damaging that area doesn't seem to have any long-term consequences. The procedure's been done for over 7 years. It doesn't lead to any long-term consequence. The reason that site is picked is because most of the circuits, the electrical pathways for AFib, tend to cluster on the back of the heart. That's why the procedure seems to work as well as it does. Most disappointing thing about the Convergent, it doesn't work in everybody. I mean, the worst thing in the world, we sat across from a patient whose Convergent worked for about a year, and then it went back, and I made the decision just to accept Afib as rhythm of choice. But to put somebody through that and then they have, but it's not work, is really demoralizing to us too. So it doesn't always work. We don't know, and the thing is, we don't know why it doesn't always work. That's the sad thing about our knowledge of Afib. Why doesn't it work? You know, that's the problem. I'll work in the back and work my way back.
Yeah, I think you addressed this before, but I just didn't hear. How long can one stay on the blood thinner without doing any damage to any, you know? Because I've been on it about 4 years.
Well, we've had patients patients have been on blood thinners their entire life.
Okay, I thought that's what you said.
There's a concern about Coumadin. There's some data coming out that Coumadin affects some enzymes in the liver, and your risk of developing renal failure is higher on Coumadin. The big risk with the drugs is not that they damage, the blood thinners don't tend to damage the body organs. What they tend to do is bleed, the bleeding risk. And every year you're on them, there's a little bit, you know, there's a bleeding risk.
Thank you.
I'm sorry, coming back up,
Yeah, what kind of anesthetic do you need for that clip?
For the Watchman,
No, no.
oh, for the atrial clip, that's done under general anesthesia. I think it's better for patients to be under, that's what I want. I mean, I wouldn't mind at all, general anesthesia. Yes, ma'am.
What's Dr. Brothers' first name?
Michael Brothers.
Mike Brothers, is he here at East Jeff or?
He's here at East Jeff. He's our arrhythmia surgeon.
Okay.
I think he's one of the best arrhythmia surgeons in the South. That may be the best arrhythmia surgeon. He's so meticulous.
Sounds like it.
I'm sorry, ma'am.
Is it possible that you can have, you know, been diagnosed with AFib? I'm a person that doesn't feel it, but it doesn't, you know, since I don't know, I mean, it's just random if I would catch it on a, you know, that little monitoring device.
You know,
Is it something that could have caused it that's no longer there?
There's
or-
been a huge realization in the last 10 years that a lot of the strokes that apparently had no cause are due to AFib that comes and goes. And now that we have these miniaturized monitors we can put under the skin, it's estimated that 1/3 of the patients with strokes without identifiable cause on the stroke unit is due to undiscovered AFib. So 1/3 of patients have no awareness of it, and we always tell patients it's a blessing and a curse. Because for me to make clinical decisions, if you know you go in and out of AFib and you can tell the minute, date, and time, I can take the history and know how to tell if the medicines are working. If you have no perceptual awareness of it, I'm between a rock and a hard place too, because I don't know if the medicine's working or not. What's the only way? I gotta do EKGs on you every time. What if your AFib only occurs at nighttime? It can look perfect, and then you're having 6-8 hours of AFib at night. You see? So
Well, that's
more
what
and
I'm wondering,
more,
not knowing, I mean, isn't it just very random that I would?
I think not knowing is worse than knowing. I think it's worse. So a lot of patients, more and more, we're using these little miniaturized chip devices. It's like an Orwellian 1984, there's a chip in everybody, to tell how much AFib is going on. But who can monitor that from your house? Every time you go by the base station, it downloads.
So that's recommended for people who can't tell?
For patients you've had, for example, I'll give you many ways it's used, but the one way it's being used more and more is if you've had a stroke or a TIA and you're looking for AFib, how long do you monitor somebody? We've had patients where it took 6 months to pick up the AFib, the monitoring. So we're putting that, I don't put them in, Dr. Zhao puts them in. That device is put in to go look for what's called occult AFib, hidden AFib, hidden or occult AFib. We use it a lot of times in our patients who've had conversion procedures because we believe that if you've had a procedure and we can prove there's no AFib, we think that it's safe to come off the blood thinner. So we use that as a measurement tool to see when we can come off blood thinner. Many ways it's used. There's devices you can put on the back of your cell phone. One device is called the Cardia device. I know many of you here have it. And it's nice. The trouble is it's not automatically always detecting things.
Well, that's what you had suggested I get, and I have, but, you know, I'm thinking if I can't tell,
Well, what we usually advise is you do random samplings, and you hope that the random sample will pick it up. But again, what if you're asleep? And we've got a lot of patients where the AFib only occurs, you see it on the monitor. They go to sleep, at 11 o'clock, they go into AFib. They stay in AFib for 4, 5, 6 hours, they wake up, AFib is gone. So you could have 100 EKGs done in the office, you know, and it will never show anything. We get that complaint a lot. Why do you have to do an EKG on me every time I come into the office? Well, it's not for financial reason, I can tell you, because Medicare doesn't pay anything for them. But we do it because physical exam is very limited to pick up AFib. Okay? A lot of patients say, well, I know how to take my pulse, and my pulse is always a rock solid 50 or 60. Okay? And you do the EKG, the heart rate's going 110. Why is that? The heart's not generating an efficient pulse wave to transmit it to the periphery, so what you're feeling down here is nothing compared to what's going on here. So we always get EKGs. Almost always, we don't get EKGs.
Can the cardiac device pick up the AFib in the lower chamber?
There's no AFib in the AFib is only in the upper chamber.
You said that the sotalol can cause the AFib to change.
Oh, can it pick up the dangerous rhythms?
Yes.
If you feel something bad and you put the device on, it would show it to us. Yeah. There's a name of that rhythm. The name of that rhythm that is caused by sotalol, it's potentially life-threatening, is called torsades. Torsades. And we had a patient die from that a year ago. I'm just being honest with you. I mean, these drugs are not. A relatively young person who died on sotalol. Yes, ma'am.
Dr. McKinney, my husband's lived with AFib since 1991,
Mm-hmm.
and he's in and out. And he's had, the Medtronic device was implanted about a year.
The link device?
Yeah.
It's been a godsend, because instead of going to the emergency room, we're able to have him monitored right from our bedside. And he says the other little device that if we're out, he can send transmissions to.
I take care of a lot of doctors with AFib. That's a blessing and a curse too.
Well, we
And
know.
every doctor I
But
know,
you did his doctor.
every doctor I know who has AFib wants to have the link device implanted.
Has it what?
Wants to have the link device implanted, so they know.
So they,
Mhm. Now, you know what's coming with that technology? They have the ability for that to be transmitted to your either phone or watch, and there'll be some automated algorithms that'll give you the report. You won't even need the doctor interpretation.
what I was amazed at is when we visited your office, how you asked his permission, can I look at your records? You put the thing on his chest and immediately his whole history came up.
Yeah.
And you
They're
were able to
amazing.
determine what needed to be done or what could be done. Can you touch on the procedure you're gonna do on him if you happen to recall? Because it's
can't- I-
moved up to next week.
I can't recall. Cryoballoon
The
or?
black-
I didn't know, my face was bandaged and I was all, I had,
The
Oh,
black
I remember.
eyes.
yeah,
Yeah, I remember.
that's me.
That was a Saturday morning.
That was a Saturday
It
morning.
was a Saturday
I had
morning.
the procedure done Thursday.
And
I
you
was
look
a
even-
mess, yeah.
Looks
Yeah.
better, doesn't
And I
it?
had to
Yeah,
go
it looks
to
a lot better.
I had to go to the ER to get it.
You talking about the cryoballoon?
Yeah.
Okay, so patients who have come and go AFib, there's a name for that, anybody know? What do we call come and go? Paroxysmal, big old fancy term for come and go.
What is it?
Paroxysmal atrial fibrillation. It means you go into it and you break basically on your own. Nobody has to do anything.
Yeah, he's never had to be shocked.
And
In
some
all those
patients, they go
years.
into it and they don't come out of it unless they're shocked, but they maintain it. So for paroxysmal AFib, think about a spark plug triggering electrical activity, and it's sending out rapid pulses. Well, those rapid pulses come from the back of the heart in the 4 pulmonary veins that feed into the heart muscle. And so if you go freeze the outer surface of the vein or burn it, you could do it either way. Think about putting an insulator cap around the vein. So the cells in the vein are trying to trigger you into AFib, but the insulator cap keeps them trapped. That's what we try to do with the cryoballoon. So for it to work, I've got to put it in the right spot. The trigger cells have to be in the pulmonary veins, and 90% of them are there. And the heart has to heal a certain way too. Because even if the device is perfectly placed and the tissue doesn't heal with a complete scar and there's one little gap, it could be only 2 millimeters, those signals can still sneak through. But in general, the cryoballoon works about 80% of the time for come and go AFib. Why doesn't it work 100%? Well, sometimes the healing doesn't occur the right way, or the cells that are triggering you into AFib come from maybe somewhere else. We don't know. Because once we put you to sleep, the trigger cells tend to go to sleep too. So you can't always tell. It's kind of barbaric to do the procedure without sedation. It's been done, but it's been done in Europe, not in the United States. Yes, sir.
I was curious to know, is anybody with AFib not a candidate for the atrial clip? Then,
It's a good question. Is anybody not a candidate? If you've had prior surgery in that region, let's say, for example, you've had lung surgery, sometimes the scarring is so dense that he can't get his way with his instruments safely to get to the appendage.
I mean, if you're like in people with constant AFib, are they still a candidate?
Oh, yeah, that's the patients who generally we tend to put it in.
Yeah,
Yeah. But if you've had a lot of surgery on your chest,
it have to be tricky.
it can be a problem because the scarring in the chest, which we call the chest of mediastinum, the scarring can be so severe that he just can't use his instruments to safely get away without tearing blood vessels. I'm not aware of him backing away on anybody, but
No.
he has looked at the CT scans of some patients and said, I don't think they're a good candidate. So if you've had prior surgery on your chest, he may back away from it. Extensive surgery, not, it depends on the surgery. So yeah, there are some patients that maybe he just couldn't physically get to it. Yes, sir?
I think it was the iLink you were talking about, the little monitor that you can implant in your chest?
It's called the Medtronic, there's now 3 companies that have it, but Medtronic was the first. It's called the Link, L-I-N-Q. Biotronic has one with a little bigger antenna that actually gives a little bit better signal, but it's a little bit bulkier. And St. Jude is coming out with a new redesigned version of it too. They typically last for about 4 years. The batteries, I mean, you've seen the device, it's not much bigger than a paper clip. But the monitoring is exceptional. I think Sharon may have a model of it.
Yeah, no, I saw the one that you had prior, and you put me on a monitor for 48 hours. The problem I had with it, I did not work out. I vegged out all weekend long.
Wait, you're talking about external monitor or the?
Yes, external monitor.
The trouble with the external monitors is that I get more complaints about putting external monitors on because the irritation of the skin tends to be substantial. The cost of the device is, the cost of that monitoring is very, very expensive. And then let's say, for example, your AFib comes and goes on a very weird pattern. Let's say it comes once every 2 or 3 months. So I put the monitor on for a month and nothing happens. Does it mean there's nothing there? No. It just means I haven't sampled long enough. Well, how long do I put it on?
Right.
And so it gets kind of prohibitive. It just gets impractical. I mean, the monitoring's better than it's ever been, but, if your symptoms occur once every 6 months, the chance of finding it by putting a monitor on for a month goes way down.
And that's my question. Would I be a good candidate for the Link? Because we spoke about it prior. When cardiac rehab.
See, I know a lot of stuff about your history, and you've had a lot of weird stuff happen to you.
Oh, yeah.
I think you'd be an excellent candidate for a Link device.
Okay, I mean, that's where I'm getting at, because, I mean, I can go home from cardiac rehab, sweating like a pig, But once I start relaxing, my chest it feels like it's gonna explode.
Yeah, I know some stuff about, we can talk about it later, but I think you'd be an excellent candidate for a Link device.
Okay.
I think anybody with AFib. Now, they're gonna start putting them in through a syringe coming pretty soon. It'd just be a syringe injection. I mean, if I had AFib, I can guarantee you I'm gonna have a Link device. When I develop my AFib, I'm getting a Link device. Because I'm obsessive compulsive and
When's my surgery?
I want to know because I want to correlate it and see. But it's not for everybody. We never try to talk. I think Sharon, who comes in the room with us a lot, Sharon comes in the room to make sure that what I say gets done. Because a lot of doctors' offices, you go in and the doctor and you have a discussion and things are agreed upon, and then memories, people can't remember. And if you don't know, I mean, if you call our office and she hasn't been in the room to know what's going on, then there's pandemonium, nothing gets done. And there's so many medical mistakes we see getting done because of poor communication. That's one of the reasons why she's there to help facilitate the communication.
Does the defibrillator give you the same information that the link device will?
Yeah, yeah, if you have an implantable defibrillator. Yeah, provided it has an atrial lead. You can get confused sometimes. If you have dual lead in the atrium, it can give you as good or better information. If you have a single lead, you can get fooled, because all you see is the heart rate in the bottom chamber increase in an irregular fashion. You can infer AFib, but you don't directly see it. If you've got the two lead system, then you can definitely see it. Yeah. Monitoring is a godsend. I think I know we make better decisions if I
They do
know
mine between 3 and 5.
how much AFib is occurring. We call it the AFib burden. And AFib burden, you'll hear doctors talk a lot about. AFib burden is the percentage of time that you're in AFib. A lot of times we can pick out triggers. For example, if we know you have a certain food, for example, let's take something crazy, and you consistently, you say, every time I eat that food, I go into AFib. Well, we can match it. You know, you can tell us what you eat. I mean, it's just the possibilities are amazing to what to do with these monitors.
Is AFib hereditary?
Yeah, unfortunately, there's a strong family component of AFib. If your mom and dad together have AFib, your chance of developing AFib over your lifetime is well over 50%. It's estimated that with the population aging, because the American population is an aging population, we had the baby boomers, you know, in the 45 to 55 range. With the population aging, it's estimated there's going to be 25 to 35% of the population over 80 is going to have AFib.
That's a lot of people.
Now, one of the reasons people ask, why is getting older cause AFib? Well, there's a long answer and a short answer. Think about the heart and the chest. The heart is not just loose in the chest. It's anchored down to the chest wall, okay? And it's anchored at spots right around where the pulmonary veins are. So think about the wear and tear. Is anybody here a mechanic? Who does mechanical work? Okay, think about the heart every day, all your life. 120,000 beats a day. Day after day, twisting motion. And basically that wear and tear causes scarring right where the attachments are, and that's why AFib is a condition of getting older. It's that wear and tear on the upper chamber. Heart is amazingly efficient mechanically. I mean, think about that. What mechanical part could last that long? 120,000 beats a day, day after day over a lifetime, 300, you know, just do the math. It's millions and millions of beats. Hearts are amazingly resilient organ. So it's that wear and tear. And we know what the other precipitating things are. Lots of alcohol intake, high caffeine intake. You know, all these kids are drinking energy drinks. That's why we're seeing 32, 35-year-old kids coming in with AFib. Population is getting heavier. So when the population gets heavier, that means there's more sleep apnea. Now, you don't need to be heavy to have sleep apnea. You can be thin. There's a condition called central sleep apnea. You don't need to be heavy. But generally, it's a heavier population, older population. Alcohol intake is higher. I mean, La Dolce Vita. La Dolce Vita is not good for AFib.
Dr. McKim, you named some things that trigger it. We've been through all of those. The weirdest thing I ever, the night we landed in the ER, was right before Christmas when he ate pralines that a lady gave him on his job. Could sugar trigger? I always thought
You
it had
didn't eat a
been
lot of sugar.
But he was
Gotta eat a
sitting
lot
there
of
eating
sugar.
pralines like there was no tomorrow, and we went in the ER at 2 o'clock that morning. This was right before bedtime.
Heavy meals can cause distension of the stomach, or reflux, or hiatal hernia are linked to
I
AFib.
lost mine.
Because the nervous system of the esophagus and stomach are linked together with the nervous system of the heart. So patients who have esophageal or stomach problems tend to have more AFib. Particularly if you have bad reflux, you tend to have more AFib. If you have hiatal hernia, you have a lot more AFib. So I'm not sure it's the sugar. It could have been the size of the meal. We always recommend patients eat their last meal well before bedtime. A lot of patients have suggested it's monosodium glutamate. I've had doctors swear to me it's the aspartame in the artificial drinks. It's hard to do that scientifically, right? But we know caffeine and alcohol are two potent triggers. Yes, sir?
I'm just curious, when you do the EKG, you've got all these leads on the body. When you're doing this link device, it's just an implant in a single location. So is it able to pick up?
It's actually able to give you, not in everybody, but in most patients, a pretty high fidelity EKG. Now remember, it's under the skin, so the skin insulation is bypassed, so you're actually closer to the heart. So the signal quality, for the most part, tends to be pretty good. We've had some patients where it's lousy, so it's not perfect, but it's rare we can't tell what's going on from a link device. We've had a couple, but it's not perfect.
Any side effects to that device?
It can get infected. Now remember, there's no lead wire coming out of it, it's just a strictly local infection. I've never seen systemic or body infection from it. Remember, everything in medicine has a good and a bad, I mean, it always has some, there's no perfect, you can have your cake and eat it too.
Two we gotta remove. There was only two we gotta remove.
Sharon keeps track of it. We've had to remove, I don't put them in, so I don't physically do the active implanting them. Dr. Zhao does and cardiologists do. I tend to make the recommendation, but they've had two that they've had to take out.
For infection?
Yes, sir.
How long does the procedure last?
The-
Are you under anesthesia or?
For the link device?
Yeah, or you just cut, slice?
A good implanter, about 2 minutes.
No, so.
No, okay, so I wouldn't miss work or anything else, or?
So how do you put in a link device? You go,
5 minutes, sounds good.
it's going to be done with a syringe in about 6 months. But typically, you come in, they give you a nice little dose of Versed, which is the happy juice. The implanting doctor takes a vial of lidocaine. He makes a little, injection. He takes a little tiny scalpel. He makes a tiny little nick. With a forceps, he lifts the skin up, slides it under, and puts a steri strip, and that's it.
Okay, so
I'm
what about
literally
stripping?
a good implanter can do it in 2 minutes.
That sounds so easy.
It is.
Is that outpatient?
Yeah, then you go home an hour later. You gotta let the Versed wear off.
I think I was in the.
So you get a magic carpet ride with it.
Yeah, when I went home, I slept all the rest of the evening.
They gave you an extra dose.
Yeah, because my Fitbit doesn't work all the time.
The Fitbits can be very misleading. A lot of patients say, I've got a Fitbit. Fitbits can confuse you a lot.
Yeah. Especially in AFib.
I don't think Fitbits are good. Cardia is good. There's a new one that I saw. I haven't seen it used yet. It's called, it's a device that's a little bit more obtrusive to use. Amazon is, I read a review on it. It's coming out in about 2 months. I'm blocking on the name.
That's like the strap on?
It's a little bit more of a strap-on, yeah.
Yeah, I saw that too.
The trouble with the cardia device is the signal quality can be bad sometimes and not so good. Yes, ma'am?
How long can you be on something like amiodarone before it gets to be dangerous?
We worry about it from day one.
Okay.
So we get asked that question a lot because patients get on the internet and read about it. If you read the PDR on amiodarone, you would never use it.
That's true of almost every drug.
Now, I've been out for close to 30 years, and I've had huge numbers of patients on amiodarone. I've only seen bad problems with it a half dozen times in 30 years. So the risk is probably more exaggerated than it's real. But in Europe, they use it in much higher doses, and they get a lot more side effects. We tend to use very low doses, and so we've had patients on amiodarone for 10 years. We want to get you off of it the very first opportunity we can. We don't want to take the risk. Believe me. But look at the alternatives. What's the alternative? So as a take-home point, if you're asked the question, how effective is amiodarone? Well, in general, if you've cardioverted somebody and you put them on a non-amiodarone drug, their risk of recurrence is 50 to 60% in the first year. Their risk on recurrence on amiodarone is about 25 to 30%. So it's a order of magnitude better meant using amio than other drugs. The other thing is amiodarone is very, very unusual to cause sudden death as a result of using it. With all its other evils, I've never seen it cause dangerous arrhythmias in the lower chamber. So that's a real concern for us, that despite all the bad stuff, it doesn't cause really bad stuff in the lower chamber. That's why we tend to use it a lot. I mean, you gotta remember, AFib in general is not a life-threatening arrhythmia. I always tell patients that AFib is not gonna be something that'll kill you. The physical act of being an AFib rarely, if ever, kills anybody. Now, the treatments can kill you, and the stroke can kill you, but AFib itself as a disease, if it wasn't for the stroke risk, is a relatively benign disease. The fact that the atria fibrillate is not going to cause a problem. You lose about 10 to 20% of your mechanical efficiency of your heart, which means if you do a lot of physical activity, you're going to feel dragged out sooner in the day. So that's a consequence. But AFib itself, and even the cardiologists believe this, and I see more AFib than anybody. I've never seen AFib directly kill anybody. Stroke, 3 times a week. I see that. That's common, because patients don't tend to be aggressively treated with anticoagulants. But kill anybody, almost unheard of. Okay, guys, we're gonna at it for a while.
We thank you very much.
I hope this was useful.
Good
Good questions. Y'all had some great questions.
One of the medicines here,
Very good. Thank you so much.
it's supposed to take 2 weeks.
Sometimes the simple question and answer is better.
2 weeks.
Format of the
One
fair
a day.
talk.
Thank you so much.
Then you refill this. I should just take one.